Good afternoon, everyone. Welcome to the FRCS Viva practice session. So today we are going to discuss on bladder cancer. We have got a couple of trainees who has agreed to record this session for the benefit of future trainees for their revision. So we'll start now. You are sitting in your one-stop clinic and you are reading a letter from the GP. Is it for a 2-week wait pathway referral of a 68-year-old gentleman with a visible hematuria? How are you going to proceed in his case?
Right, I see him in the clinic as mentioned with the cancer specialist nurse. I'd like to start with a focus history, do a chaperone examination, and then prescribe investigations. I will ask him for how long he has had these symptoms, what kind of hematuria it is, whether he is having clots, whether he has had any episodes of retention along with it, whether he had any colic. I'll also ask him for any low unit tract symptoms otherwise in terms of his voiding and storage symptoms. I will ask him for whether he's had a fever or any other incidents and red flag signs such as weight loss or pedal edema or lower limb swelling. I'd ask him for history of his smoking, if he's had exposure to chemotherapy, particularly cyclophosphamide, and if he's had any radiotherapy in the past or any previous abdominal or urological operations. As part of the chaperone examination, I'd examine his abdomen, palpate his lower abdomen, check if he's got a palpable bladder, evaluate his external genitalia. I would also, with consent, administer a digital rectal examination. I would examine his extremities for edema and check for jaundice. The investigations I'd like to ask for a full blood count, using these with creatinine in case imaging is required. I'll ask for urine cytology, and I'll take things from there. I'll be consenting him for a flexible cystoscopy.
Okay, so he's 68-year-old, as mentioned, and 4 weeks history of visible hematuria, no urine retention, no dysuria, no flank pain. He is not on any regular medications, no family history. He is a smoker of about 10 cigarettes per day for almost 25 years. Clinical examination otherwise normal, no pedal edema, DRE normal. You said that you will do urine cytology. Will you do urine cytology for all patients coming to hematuria clinic?
I'm sorry, I'll take that back. Urine cytology may not be very sensitive when there is hematuria. It's not cost effective either, so I'll take that back. I'm sorry.
Okay. So this is a scenario now. His bloods are normal, otherwise normal. Urine dipstick, except for 4 platelets in the urine dipstick, everything else is normal. No signs of infection. How are you going to proceed? So you said that you're going to do a flexible cystoscopy, isn't it?
Yes, so I'll explain to the patient that his referral was because hematuria is a sign of a possible bladder cancer, and from our existing information, we know that about up to 25% of referrals at his age for visible hematuria turn out to be malignant. What I need to do to complete his workup is to offer him a cystoscopic examination under local anesthesia. Since he's come with visible hematuria, I'll also like to organize upper tract imaging, which will require him to visit a CT scanner and have contrast instilled as well.
Okay. So what's the evidence that you said that? I mean, what's the evidence base to say that 25% will have?
So I appreciate this is not the most current evidence, but this is from Kadra et al., where he had a study on outpatient clinics where they had looked at in the area of IVUs. They had done cytology, flexible cystoscopies as well as IVUs, and found that approximately 25% of patients referred for visible hematuria had urothelial malignancies, and non-visible hematuria was about 10% or so. This was backed up by a subsequent study by Edwards et al., where they had a slightly lower incidence, so about 20% urothelial cancer with visible hematuria and about 5% with non-visible hematuria.
Are there any new evidence for hematuria pathway?
Um, I'm aware of evidence for IV versus CT, but I can only quote the NHS guidelines.
What is Identify study? Have you heard about
I,
Identify
yes,
study?
Identify is a study which is sponsored, which is done by Burston, partly sponsored by the BOWS.
Mhm.
So this was to look at the outcomes of visible hematuria in one-stop clinics. I'm not sure of the report.
Okay. So, and you said that you will do CT urogram, isn't it?
Yes. Yeah.
And what's the
Ideally
reason
speaking.
that you are doing CT urogram?
There are some clinics which will do an ultrasound at the first instance, but for visible hematuria in my trust, we would organize an urgent CT urogram after checking his creatinine.
Okay. What is the chance of, or what's the incidence of upper tract urothelial cancer in visible hematuria?
So synchronous upper tract cancer could be about 5% to 10%.
That's when a bladder cancer is diagnosed, isn't it?
Yes, correct. Yes.
If the patient is coming with visible hematuria, what's the chance
Okay.
that? Okay. So you are doing the flexible cystoscopy for this patient.
Yes.
The finding that you are seeing is a papillary tumor in the right posterolateral wall. You think that it is about between 3 to 4 centimeter. Rest of the bladder normal. Both UO normal. The tumor is very well away from the right UO. Because it is a one-stop clinic, you already got the CT urogram
Yes.
and arranged, and the upper tracts are normal. How are you going to proceed? His urethra is normal. How are you going to proceed?
So I will counsel this gentleman along with the cancer specialist nurse. I will explain to him that I have found a lesion which I will also show to him on table and say that this is very likely to be a malignant growth and that we need to remove this completely and send it to the histopathologist for a final confirmation. We will also at that point of the operation get information about how deep that has gone, and that will influence the management. I'll also inform him that the CT scan has so far shown that there is not any upper tract involvement. I will speak to him about with a procedure-specific consent form as well as give him patient information leaflet from BOWS. I will speak to him about the risks and complications of this procedure. Primarily, I'd like to talk to him about the incidence of hematuria postoperatively, which is almost universal, some mild hematuria, which would settle in a few days. I will try to make sure that I don't need to put a catheter, but he may need a catheter for a day or two if there is some bleeding at the operation. I will speak to him about the chance of having a bladder perforation since it's on the, I think you mentioned towards the dome. And that should be around less than 1%, which may need very rarely an open operation to fix the perforation. I'll also speak about the chance of finding other small malignancies which we had not found in the initial flexible scopy, and those will also need to be removed. I will likely administer intravesical chemotherapy at the end of this procedure, which will be evacuated while he is in the recovery, and that will not affect his discharge plan. He should be able to go home the same day, if not the next day, if there is a bleeding or any other concerns. Subsequently, I will wait for the biopsy to come. This will be then discussed along with imaging and information about his performance status in general health at the MDT meeting. And depending on the stage, then the decision will be taken about further treatment.
So you said that you will likely give single installation of intravesical chemotherapy, isn't it?
Yes.
Why likely?
So that depends on a few things. One is the size of the tumor, the presence of whether it's unifocal or solitary, and there should not be any other complications such as a bladder perforation.
Okay. Do you use any adjuvants in the sense that for imaging?
Yes, so that's why I mentioned that there may be some other lesions not picked up. So in my practice, we use a narrowband imaging to detect, to look at the tumor, look at all the other normal areas of the bladder, and also confirm that the resection has been complete. If you'd like me to describe it, this is done by a single switch on the same set. It's an Olympus stack. and this uses a wavelength of blue and green light. So that is usually between about 440 and 515 nanometers of light. This will have a differential absorption. The tumor will absorb more of the light because it is highly vascular, whereas the rest of the mucosa might reflect most of it and therefore look white. There will also be a difference in the absorption based on the blue, which will be absorbed less, or depth of penetration less than the green. And this difference in absorption will create the contrast, which allows us to compare with the white light imaging as to whether the resection is complete.
Okay. So you are seeing this patient in the surgical arrivals on the day of the procedure. You have consented the patient for white light histoscopy plus narrowband imaging and single installation of intravesical. So which chemotherapy do you use?
So we will use intravesical mitomycin, dose being 40 milligram. I mixed in 40 ml of saline as well as a dwell time of about 40 minutes.
Okay, so you have consented him for the SIIVC, single dose intravesical installation of mitomycin. Imagine that you are in the theater. So the WHO checklist is done. The patient is in lithotomy position. Antibiotics given. Stop check done. You are going to start the procedure. Can you take me through the procedure? How do you do that?
Yes. I will inform the anesthetist that I'm about to start the procedure. I will initially do a preliminary scopy, which is usually with the 21 French sheath cystoscope. I will, according to the AU advice, I will look at the urethra carefully, look at all the aspects of the bladder. I will also, prior to this, I will do a bimanual examination and check if the tumor is fixed. Subsequently, I will convert to using a resectoscope, which is usually 25 French. I will use a narrowband imaging with a regular cystoscope to have a look at the bladder before this. With a resectoscope, I will be using bipolar energy. I will resect this tumor piecemeal. Since it's in the towards the dome, I will take care not to cause a perforation. I will maintain the irrigation at a reasonable level and make sure that my outlet is working well. I do not want the bladder to be over distended. Having completed the superficial resection, I prefer to evacuate these chips and then take a separate deep resection. Following completion of the deep resection, I will check back with the narrowband imaging to see if my resection is complete, and then I will fulgurate the edges as well as any potential bleeders at the base of the bladder. I would have evacuated the deep chips by then. Once I've checked that hemostasis is complete, I will put in a catheter, make sure that there is not excessive hematuria, then drain the bladder, instill the mitomycin, clamp, put on the stopcock, and then start the timer for the mitomycin and inform the nurses as well. It will be a three-way, and we will remove the mitomycin in the recovery. I do this myself, and subsequently, if necessary, start on irrigation, or if not, the catheter will be removed.
Okay, so we'll stop there. How was it?
I think I gave you some wrong numbers. I'm sorry.
No. You don't have to apologize, please, because this is like a learning thing only. This is more like a reflection. So whatever you can't answer, maybe it's not because you don't have the knowledge. It's as I said before, it's because of the holding the nerves. So never apologize, okay? And it's more. So you have to just go through the. Sorry. So you. I think it was good, really good, because there was no concern regarding any patient safety, things like that. Couple of things are. These are the time. This is one of the questions where you can emphasize more on one-stop clinic concept.
Yes.
Where the patient will have the imaging on the morning session, in the morning session, and then come to the outpatients in the afternoon to have the flexi. So we can emphasize on that part if that is good. And regarding the Identify study, I highly recommend read Identify study, because the Identify study compared, there are 3 arms that they compared. It's a multi-center study. Burst, led by Burst, and it compared visible hematuria, non-visible hematuria, and also retrospectively bladder cancers that were not presented with hematuria. And for visible hematuria, the incidence of bladder cancer in this one almost similar to the Kadra or Edward study. So it is 22.4, and upper tract urothelial cancer was 1.6%. So I would highly suggest to be aware of the Identify study, and also
Yes.
you can now get a scenario where the patient is not willing for a flexible cystoscopy, in which case there is an Identify risk calculator. Just so you can introduce a risk calculator. So it's nice to tell them that you are aware of the options. The Identify risk calculator will give us a number, and depending on if it is less than 5% or if the risk is more than 20%, we can divide into low, intermediate, and high risk. So we can counsel the patient based on that. If the patient is a high risk, and if the patient doesn't want flexible cystoscopy, we can counsel that. See, this is the number, and you are at high risk of having a bladder cancer. Only if that situation arises. Otherwise, you can just mention that you will counsel the patient on the risk of bladder cancer using an Identify risk calculator, which is really good because that's why we do all these studies, isn't it?
Yes. Yes.
And regarding no concerns regarding the investigation part, everything was straightforward. Cytology, yeah, that's always a catch point. You don't have to bring that in, because
Yes.
once you say that, then it's like going down the rabbit hole. So never mention only the things that we really do, especially because when the patient is having an ongoing visible hematuria, there is not much of role of cytology, because it's very difficult for the pathologist to identify, because there is lots of RBC. There will be lots of RBCs in that specimen, so very difficult for them to identify a high risk tumor. Then coming to the counseling part, it was really good. You involved the nurse, you gave the, but it can, I would think it can be really, you can trim it down to 40 seconds or 60 seconds.
Okay.
You have to, because that one won't give you much. That is just to assess how you approach the patient. You won't get much mark on that one, but you will get more mark on how you do a resection, because that's more important, isn't it? So when you come to the resection, no concerns again. I'm because there are two schools of thought. Why do you want to do a normal cystoscopy first? Because you already did the flexible cystoscopy. You know what it is there. So
so that depends on whether I have a NBI with my flexible cystoscopy in the clinic or not. We don't have one, so I do it in theatre.
But you can do that with a resectoscope, isn't it?
You can do it with the resectoscope as well.
Yeah, because that's the camera that matters, and it is a filter that you can change. Even for PDD, you don't have. You can go with the resectoscope.
True, absolutely.
Because the scope doesn't matter. So maybe that question might arise: why you want to do a cystoscopy first and then do a then introducing the resectoscope later. So that question might arise. EUA, very important. You covered that one. No concern about that. Resection. It's better to introduce because all these are based on the EAU guidelines, isn't it? Because the NICE guidelines is 2015.
Yes.
Yet to get updated. So we have to rely on EAU guidelines for all the new things. So according to the EAU guidelines, there are two types that is described, isn't it? You can do either the piecemeal resection or the en-bloc resection.
Yes.
So it is better because what you described is a piecemeal resection. So you can bring that term. I'll do it as a piecemeal resection, where I remove the exophytic part first, 1, 2. Then I remove. I will do some deeper resections, 2 and 3. I'll make sure that the edges are resected as well. So there are 3 steps for piecemeal resection. Again, you can say that one question is asked is, how are you going to measure the size of the tumor? You can say.
So measure the loop if it's a small tumor.
Sorry.
You can measure it according by the side of the loop, the resection loop, if it's a small tumor.
So how do you measure that?
I think across it's about 8 millimeters or so, but I'm not entirely sure.
Yeah, EAU says that is 1 centimeter, isn't it?
Sorry?
EAU says that it is 1 centimeter. The loop is 1 centimeter, isn't it?
I have to look that up.
Yeah. So
Thanks.
that's why. So previously we didn't have the answer for that, but EAU luckily came up with that one. So we can say that. I mean, so that's how we measure it. And once you measure it, because that's very important. And a couple of things I would think that was missed was everything went well. You put the mitomycin. The question is how long you will keep the mitomycin for, because that's the question, that's the answer that the examiner is looking. Otherwise, if the examiner has to ask that question, that means that that's a prompt.
Yes.
So how long you will keep it for?
So that's 40 milligram, 40 ml for 1 hour.
1 hour. Yeah, excellent.
I said 40 minutes. I'm sorry.
Yeah, because we have study between 30 minutes and 1 hour, and we know that 1 hour is better than 30 minutes in preventing the recurrence, but there is no study comparing 1 hour and 2 hour. So
Yes.
that's why we rely on 1 hour. And again, comparing, you have to think about the op notes. You have to say that we will record everything intraoperative findings in a, better to use a pro forma, especially in TURBT.
Yes.
Because the RESECT study
Yes.
is ongoing now, and from what we learned from the RESECT study is, if you have a pro forma, then your standard of recession goes up,
Yes.
and the chance of recurrence can also come down when you have a pro forma, and the recording will be good.
Can you please repeat that with the RESECT study?
So RESECT study looked into mainly 4 parameters, isn't it? So they looked into detrusor muscle, intravesical installation, TURBT pro forma, and there was one more variable that they looked for. So how much you record in a TURBT pro forma is one of the variables, and they say that if you use a pro forma, the quality of your recording, the quality of your resection, the chance of recurrence is less, because if your recording is good, that means that you have to record everything, isn't it? How many tumors, whether you have used an adjuvant like a PDD or a NBI, things like that.
Okay, thank you.
And that is based on a paper by Mariappan. You will come across it. I think it was in 2020 they published that one, using a TURBT specific pro forma has got the advantage.
Mr. Bushkan, there is echo with your voice.
Sorry.
There is echo with your voice. Can you correct, please?
I'm not sure how I can do this. So let me do one thing. Is it better now?
So I can hear you quite clearly, except that once in a while the signal cuts off briefly, very briefly, but there's no echo on my side.
Oh, okay. So what they say is, for the completeness of resection, can you hear me now better?
Yes, we can hear you better now, and there is no echo.
Excellent. So yeah, I remember now. So the RESECT study mainly looked into 4 parameters. One is the detrusor muscle present or not, whether you are giving single dose of intravesical mitomycin, and whether you document in a operation notes the completeness of resection, and whether you are using a pro forma to record the number, size, and tumor location. So it is better to say that I will use a TURBT specific pro forma, because everyone is aware of RESECT now. So if you put that keyword there, then you can show that you are aware of the newer things going on in the field of bladder cancer. Can you hear me? Okay, excellent. What else? And yeah, it's always better to say that I will review the patient afterwards. You said that you will remove the catheter yourself, but in a way that if you can say that I will review the patient afterwards and make sure that there is no other signs. Mainly we are looking for perforation and making sure that he or she can be discharged on the same day.
Okay.
Excellent. Hope that was helpful.
Thank you.
Yeah. Shall we go for the next one?
Oh, yeah.
Excellent. So you are sitting in the MDT, and this patient's histology is being discussed. What all things you need to know from the histopathology report?
From the histopathology report, I would like to know the T stage of the tumor. I would also want to know about the grade of the tumor. Other is whether it's a multifocal or a single tumor, the size of the tumor, whether it is more than or less than 3 centimeters, because we risk stratify or do a calculator to find out the evidence of recurrence or progression, and any evidence of CIS.
Okay, so the pathology says that it is G2 PTA high grade, and from the op notes we know that it is a 3 centimeter single or solitary lesion in the right lateral wall. The op note says that it is complete resection and there is no muscle in the specimen. So,
Right.
yeah, how would you want to take it further?
Yeah, so of course I missed on that part that I would have asked for a muscle present or not. In this case, he's got a high grade TA tumor. I would call back the patient in my clinic and discuss with him about the further management plan. I would counsel him for a re-resection or a restage TURBT in 2 to 4 weeks time. I would also obviously do a risk calculation by the EORTC to find out about the risk of recurrence and progression based on the parameters which I mentioned, and plan for a restage TURBT.
Okay, so what risk category is this patient?
He is into high risk risk stratification based on the NICE guidelines.
It is a PTA.
Sorry, I missed on. I think it's G2 high grade. You mentioned 3 centimeter. Yes, so he is into intermediate risk stratification. I'm sorry on that.
Okay, so you decided for a repeat TURBT, re-TURBT. What's the reason for re-TURBT?
For a high grade disease, it is seen that there is one evidence is basically the muscle was not present in the specimen. So for completeness of the staging, I would plan to do a re-resection in this case. Secondly, there is chance for upstage or upgrade of the disease in case of high grade tumors by the tune of about 15 to 20%. So for that reason also I would consider doing a restage TURBT.
Okay. Will you instill mitomycin C when you do re-TURBT?
So the benefit of instilling mitomycin C again on a restage TURBT would be if there is less than one recurrence present, or when the EORTC calculation score is less than 5, then definitely there's a benefit of instilling mitomycin C.
Okay. So your patient agrees for repeat TURBT, and you did the re-TURBT, and when you are in the MDT again, this time the pathologist says that there is an upstaging, as you have suspected. It is T1G3. Muscle is present again, but not involved.
Okay.
Okay. So this time you have used the photodynamic diagnosis. So hopefully there is no other tumors left. What is photodynamic diagnosis?
So photodynamic diagnosis or a blue light cystoscopy is basically used to find out any evidence of concurrent lesions in the bladder. It is a process where we instill 5-amino-levulinic acid into the bladder 1 hour prior to the surgery, and we use a blue light which has a wavelength of about 450 nanometers. The tumor cells are picked up, which shows a red fluorescence, and we can biopsy or subsequently resect these lesions. It is shown that to reduce the risk of recurrence to the tune of 10%, and also it has picked up higher high grade as well as carcinoma in situs in cases. I'm also aware of the photo trial which showed comparison of photodynamic versus standard TURBT, but there was no evidence, no benefit of 3-year recurrence-free disease in both the study groups.
Okay, excellent. So you are sitting in the you are the bladder cancer lead for this MDT. What are you going to do for this patient?
So he's now got an upgrade of this disease to T1 G2 disease. In this case, I would call back the patient to my clinic in presence of a cancer nurse specialist. Also, I would like to ask a family member along with the patient and discuss about the further management plans. I would counsel him for two options. One is going for an intravesical adjuvant immunotherapy in the form of BCG, or counsel him for early radical cystectomy as well.
Okay, what's the advantage of having a early radical cystectomy?
Well, the advantage of early radical cystectomy, it is seen that the patients who have an upfront muscle invasive disease, as compared to a patient who had a high risk, T1 disease, which progresses to muscle invasion later on, the survival is poor in the second group of patients.
Any numbers for that?
The 5-year survival is up to 60% in patients who have progressed from a T1 to muscle invasive, as compared to upfront muscle invasive disease. But I'm not sure about the numbers, I guess.
Okay, you said it right. What is the mechanism of action of BCG?
Right. BCG is basically a Bacillus calamit-guerin. It is a live attenuated Mycobacterium bovis. It attaches to the urothelial cells by the fibronectin receptor and enhances the immune system, leading to the killing of the tumor cells.
Okay. And what are the side effects of BCG that you would counsel the patient for?
Right. So the side effects for the BCG mainly are lower urinary tract symptoms, which could be bothersome sometimes in the form of frequency, urgencies, hematuria. He could have BCG cystitis, which again presents with low urinary tract symptoms. Sometimes there could be organ involvement in the form of granulomatous prostatitis or epididymoarthritis as well. And very rarely systemic symptoms in the form of high-grade fevers can manifest as well.
Okay. And how will you plan the BCG? What is the regime that you will plan for this gentleman?
So he's got a T1 disease. Clearly, it's a high risk stratification based on NICE guidelines. I would plan him for BCG regimen based on Lamb's regimen, which includes 27 installation. Initially, induction phase, which will include 6 installations, 1 weekly, and subsequently maintenance phase, where he'll receive 3 installations at 3 months, 6 months. And from there on, every 6 months till 3 years.
Okay. So, this patient, when you discuss with him, he is willing to have the BCG. What type of BCG strain is used in your hospital?
I'm aware of a few strains, but I'm not sure which strain we use. So I know of Danish 1331, Pasture, Connaught, and RVIM strain, but I'm really sorry, I don't know the strain which we are using at this moment.
Okay, so you refer him to the nurse-led clinic for the intravesical BCG installation, and your nurse has referred him back after the induction phase, and you did the flexible cystoscopy after 3 months after the initial induction phase. Now, when he comes back, you can see a papillary appearing tumor in the posterior wall. What?
Okay.
Okay.
Yeah. So I will again put this case in our MDT meeting for further plan of management and counsel the patient for a TURBT or probably a cystoscopy and biopsy to find out the stage of the tumor.
Okay. So why this has recurred? What is this condition called?
So in this case, he likely might be having a BCG refractory disease. Depending on the histology we find on the surgery.
Okay, so the histology shows it is T1G3, TRBT histology.
Yeah, so clearly he has a BCG refractory disease. In this case, he's not likely to further respond to BCG therapy, and I would counsel him for an early radical cystectomy.
Are there any other options? If the patient is not
The other
radical cystectomy.
Yeah, so if patient is not filling or is not fit enough for a major radical surgery, the other options are using electromotive therapy, using mitomycin C or hyperthermia induced, installation of mitomycin C as well.
Okay, we'll stop there. So how was it?
Okay, I obviously goofed up on the beginning histology itself. I didn't realize it was G2 high grade. I thought it's T1 initially, so I said high risk and other stuff. So I started wrong on a wrong note actually.
No, I mean this is the catch point in always, because nice guidelines, only nice guidelines says that PTA G2 high grade is intermediate risk. So whenever, always listen carefully whenever the histology says if it is TA G2 high grade. If you say that it is a EAU, then it is a high grade. I mean high risk disease, isn't it?
High risk disease, yes.
Depending on 3 other parameters as well. But still, if you are sticking to nice guidelines, which we almost follow in our MDTs as well.
Yeah.
So
I agree.
That's the catch point there, because otherwise all high grade can be considered as high risk. Only PTA G2 is considered to be high grade, is considered to be intermediate risk.
Yes.
That's a favorite question of examiners. That's why it always comes through. And but there's no problem in that one, because you came back. Because you didn't proceed with saying that it is a high risk. So and the repeat URBT, single installation mitomycin C is not usually indicated, because the indications are the first one, and also the EAU guideline says that, and also again this is from, I think it is Mari, we have to confirm that, I think it is again Param Mariappan's paper, where it is we give it for recurrences more than 12 months, papillary recurrence more than 12 months. So these are the indications for intravesical mitomycin C.
Okay. I don't know, I thought I read it somewhere that it'll be benefiting for EORTC probably with score less than 5 and less than 1 recurrence a year kind of. So maybe I might have to just check on this again.
Because usually we give for these 2 indications here.
Right. Okay.
And then you said it right, because the difference is 60% versus 90%. You said about 60%, and the other one is 90%. If you are if you are going for a upfront cystectomy.
Yeah.
And then no other concerns regarding BCG strain. Yeah, it's better to know about it, because that's a common.
I'll check it. Yes.
So in our center we use oncotice 81 mg. So better to know that.
Right.
Again, you are updated about photo trial, which is really good. Well done.
Yeah.
Systemic things. Yeah, I think we have covered everything in that aspect. I think the EMDA, sometimes there will be more questions on EMDA in the technology session. So what are the principles behind EMDA? Same thing for hyperthermic mitomycin C. How would you instill it? What is the principle behind mitomycin C? Sorry, I mean hyperthermic mitomycin C. There is a good module in the BJUI knowledge for BCG resistant BCG failure. Or BCG relapse patients. That's one of the good modules that I have that helped me to prepare on that aspect of the topic.
Right. Definitely, I'll have a look at it.
Excellent. Shall we go for the last session then?
Yes. Thanks. Thank you.
Can I just ask a couple of questions, just quickly, please?
No problem.
So, as you said, if it was high grade G2 PTA, if you say that would be high grade with EAU guidelines, which way would the station then go, or would they kind of pull us back and say no? What would it be according to NICE because they want to discuss BCG?
It is better to discuss in the NICE guidelines, because in UK we follow that, isn't it? And in which case it will be mitomycin. But again, it's a bit of controversy in that sense, because possibly once the NICE guidelines gets updated, that will go into the high risk, we believe. But it's all depends on showing, I mean, how you explain it. If you say the only problem here was when the answer was given, it was said that it is high risk according to NICE guidelines.
Yeah,
So
okay.
that's
So you
one
have
thing
to
that
say
you
no,
have to be
according to
careful,
NICE
according-
guidelines, it's actually intermediate risk.
Exactly.
Yeah.
And it
Yeah.
also,
Thanks,
and also-
Martin. And then could you just clarify with BCG in terms of flexible cystoscopy and rigid cystoscopy, how frequently it's done? Because I've read so many different things. Do you do flexible cystoscopy after the first 6 weeks, after the first induction of BCG? Or is it a rigid and a biopsy?
there is no. I'm not sure whether there is any specific guidance given for that. It says that cystoscopy, so it depends on your center. In our center, we do the flexible cystoscopy, and if there is anything abnormal, then go for the biopsy if needed.
Okay, and then
Especially because this was a single tumor, isn't it? Sorry, this was a single tumor, isn't it? Solitary tumor, less than 3 centimeter. So, and we used the PDD as well previously.
So about the induction, we do after 6 weeks. We do after cystoscopy after 6 weeks. So what about the maintenance dose? When do we follow up those maintenance dose patient with flexible cystoscopy? Is there any schedule?
Yeah. So the cystoscopy can be done 6 weeks after the BCG, where we think that the BCG cystitis will be better. So we can
Okay.
you can schedule
I
like
mean,
that.
so we are in the maintenance group. We are following 6 months, 12 months, and then 18 months. So after finishing the regimen, we wait for 6 weeks and do a flexible cystoscopy
Yeah.
before the next one.
Before the next one, we have to do that because there is always the risk of this BCG failure.
Yeah. Thank you.
And it was really good that the previous candidate said about the difference of 60 and 90%, because that's the thing that makes a difference. We have to counsel the patient based on that, because he's only 68, he's fit and well. And one of the questions that can be asked is, if the patient agrees for a cystectomy, will you give any adjuvant chemotherapy? But we don't have any evidence for that, isn't it, in these cases?
Okay.
Excellent. So shall we go for the last one then?
Yes.
So you are sitting in the MDT, and one of the cases being discussed is about a fit and well gentleman who is a chronic smoker. He is only 62-year-old. He came with hematuria, upper tracts normal. CT is not showing any lymph nodes or anything in the pelvis or in the other parts of the abdomen. Chest is also, CT is normal completely. CT abdomen and pelvis is completely normal, but the TRBT shows muscle invasive bladder cancer, T2.
Okay.
Any other
Muscle cancer, T2. Okay.
What are the other investigations would you prefer to have for this patient?
So this patient already had a CT scan with no metastasis. So I can do an MRI of the bladder to look at to stage the bladder again. If I feel that I need to further look for the bladder invasion, MRI of the bladder. The patient already had no lymph nodes, so I won't be doing any kind of PET CT scan to find out any indeterminate lesion. I would like to do a chest CT scan to have a look whether it's metastasis to the bladder, and also if there is any complaint of bone pain, I would like to do a bone scan.
Okay, so what's the classification of used in the bladder MRI?
Classification of bladder MRI. Okay. So it's sorry, I can't remember that. Can I come back to that again?
Yeah, sure. So how do you classify the end staging in TNM?
So TNM end staging is done when there is N1 is when there NO is no lymph nodes, NX is undetermined. N1 is when there is a single pelvic lymph node. and N2 is multiple pelvic lymph node, and N3 is non-regional lymph nodes.
Okay. Okay. So this patient is his pathological staging is T2. MRI bladder, including the pelvic area, and the CT doesn't show any lymph nodes in the pelvis. Chest is clear. No other symptoms, no bone pain, no headache, no other symptoms. He's otherwise fit and well. What will be your plan for this patient?
So I will. This is a fit and well, although a smoker, 62-year-old old male patient. I will offer him a radical cystectomy as a standard of care. And also, I will offer him the alternate options such as radical radiotherapy and options of doing nothing, which means that it's already an invasive disease and it will likely to progress and metastasize soon. So these are the options I'll give the patient. I will see this patient in my clinic in presence of cancer nurse specialist. I will give him the Bowes information leaflet regarding radical cystectomy and also about radical radiotherapy. And I will discuss in brief about his histology and about what are his treatment options and what are his chances of success rates following radical cystectomy. Having a T2 disease, we are expecting a 5-year survival rate of 60%, and with no lymph node metastasis. That is, and I will go through the radical cystectomy option with him and before and discuss with him in the MDT meeting.
Okay. What's the role of neoadjuvant chemotherapy in this patient?
So this patient, neoadjuvant chemotherapy, if there is no lymph nodes, I think there is no option for neoadjuvant chemotherapy at this point. But usually cisplatin-based chemotherapy is given. Sorry, there's in my head at moment about this.
Okay. And how you said that you will counsel for the radical cystectomy, isn't it? So what approach will you counsel him for?
So the radical cystectomy can be done by open or robotic approach. It has a high mortality rate of 3% and a morbidity rate of 30%. And the patient will have his bladder removed, and another conduit, preferably an ileal conduit, will be performed to drain his urine. So there will be a stoma to one of the side of his abdomen to drain the urine. The patient, depending on the histology after radical cystectomy and the histopathology, may require adjuvant treatment options such as adjuvant chemotherapy if he had any chemotherapy. I will talk him through about the risk of having radical cystectomy, which includes infection, bleeding, early and late complications. Early complications includes paraoperative bleeding, injury to the surrounding organs such as bowel, big vessels, injury to the rectum, and also injury to the vessels. Early complication can be lymphocyl after lymphadenectomy, and they can be anastomotic dehiscence, and also they can be burst abdominal wound dehiscence in the early postoperative period. They can be in the late complication. It can be either following in the ileal conduit. They can be peristomal hernias. They can be stricture of the uretero-ileal anastomosis, and they can be recurrence of tumor in the upper tract later on. So he should be having a surveillance for that.
Okay. And is there any evidence to compare the outcome between robotic and open cystectomy?
So I'm aware of an evidence that there is literally in the robotic cystectomies, the patient hospital stay is short and patient recovery is quick. And less blood loss in compared with the open. But the oncological outcome, I think, is the same.
Okay. What is ERAS?
So ERAS is a extended recovery, early recovery protocol in a patient having a major surgery, where the patient recovery is enhanced by setting him to a specified protocol. So he's given, so his early mobilization and early enteral feeding is ensured, and also the pain, effective management of pain control, so that the patient recovers early and having a short hospital stay, as well as avoiding complications.
Okay. So your patient agrees for, he wants to go ahead with a robotic radical cystectomy. Regarding the lymph node dissection, what level of lymph node dissection would you prefer?
So in this preoperative CT scan, there were no lymph nodes. So I will clinically look for whether there is an obvious enlarged lymph node on my during my perioperative period. I usually do a standard lymph node dissection, which is a lymph node dissection of the pelvic lymph node up to the bifurcation of the common iliacs. So it includes the external iliac, internal iliac, and obturator nodes, and also lymph nodes up to the bifurcation of the common iliac.
And what are the lateral boundary and medial boundary and the inferior boundaries?
So medial boundary is the bladder itself. Lateral boundary is the obturator nerve, and the superior boundary is at the bifurcation of the iliacs. And below is the cloacoid ligament, I think.
Okay.
Cloacoid nodes. Yeah.
And for the urinary diversion, what are the different types of urinary diversion?
So urinary diversion can be continent, can be incontinent urinary diversion, can be continent urinary diversion. So continent urinary diversion, the patient can have an orthotopic bladder with a radical cystectomy, so he can be continent. They can be a Indiana pouch with a continent with a metrophin to make it a continent urinary diversion. And about the incontinent urinary diversion, it's just a conduit which drains the urine into a bag, stoma outside. So it is namely ileal conduit.
Okay. So what's the difference? What is the advantage of ileal conduit over a continent urinary diversion?
So ileal conduit in terms of long-term, I think performance and long-term in terms of long-term, the ileal conduit has the better chance, I think better success compared with the incontinent continent urinary diversions, and the success rates in the incontinent urinary diversions, usually the patient has to self-catheterize to empty the bladder if he has an orthotopic bladder, and so he should be aware of that, and he should be maintaining that with a good hand function, and recognize, and with the also comes with complications. Orthotopic bladder late complication can include a rupture of the anastomosis, bladder perforations, mucous plug formations, and chance of secondary and chance of malignancy recurrence in that areas. And also about the ileal conduit, there also is not devoid of complication too. So they can be parastomal hernias, stomal stenosis, stomal ischemia, and as well as there can be metabolic complication, hyperchronic metabolic acidosis, which has to be looked at.
In ileal conduit?
Yes, in all of them, in any kind of urinary diversion, hyperchronic metabolic acidosis. But usually these are less pronounced. If the patient does not have severe renal or liver failure, this doesn't usually become apparent.
Okay.
But if it's apparent, it can be managed by sodium bicarbonate.
What are the contraindications for a orthotopic neobladder?
So if the patient has a tumor in the prostatic urethra, if there is widespread CIS, and if the patient has poor hand function, severe renal or hepatic failure, these are usually the contraindications.
Okay. So we'll stop there.
Okay.
How was it?
It wasn't good. It wasn't good at all.
No, it was good. I wouldn't say
It wasn't good. It wasn't good.
No, in the sense that neoadjuvant chemotherapy, I think we should give neoadjuvant chemotherapy for all patients, because it's not, our concern is not the nodes or anything, isn't it? It's like it's a micrometastasis, possibly beyond the level of the invasion, which are not picked up by the scans.
Okay.
And also the 5-year, we all know that the 5-year survival of radical cystectomy is only 50%, and even the audit data, the BOWS audit data shows that it was around 30% at 1 year. So there's a high,
1 year.
yeah, there's a high mortality rate for after radical cystectomy. So that's why neoadjuvant. And regarding sometimes because that evidence will come, that question will come definitely if you are asking discussing on neoadjuvant chemotherapy. The standard is to give neoadjuvant chemotherapy, and the evidence. Do you know the evidence? Just to discuss about the evidence. Do you know the evidence of neoadjuvant chemotherapy?
Sorry, I haven't revised Bladder for a long time. I forgot.
Okay, it's fine. So
Advanced bladder cancer.
Yeah.
ABC trial, but you have to realize that it was done in 2005, I believe. So it was like years ago, that evidence, 8% improvement in 5 years with a number need to treat of 12.5. But there are newer trials in 2016. There was a meta-analysis by Yin that is being that's what the EAU guideline says. So it's better to say that ABC is a classic trial. It is one of the landmark trial for neoadjuvant chemotherapy, but don't stop with that, because that trial was done in 2005. So it was like almost 18 more than 17 years ago. And it's always better to bring the new meta-analysis, Yin meta-analysis 2016.
And with the Yin meta-analysis in 2016, what percentage survival benefit does it show?
8%. So the ABC was 5, isn't it? So
yes.
This was 8. So that's why we say that 5 to 8.
5 to 8. Okay, so Yin said 8. Okay. Thank you.
And this is one of the difficult scenario. If you haven't, this is a scenario that I got from my bladder cancer station. So all these boundaries of dissection, what is extended lymph node dissection, all these questions can come. And ERAS, it's very, very important that you have to have your own way of explaining what is ERAS. Saying that because it's couple of keywords that you have to remember for it. It is enhanced recovery after surgery, and it starts before the surgery, isn't it? So it is a series of steps or series of pathways that we follow, starting before the surgery, pre-operatively and intraoperatively and post-operatively. And you can say a couple of things like pre-operatively optimizing the patient, optimizing the hemoglobin, and then intraoperatively using the minimally invasive techniques, avoiding a drain if possible, and post-operatively removing the catheter sufficiently early enough as permissible, not if a orthotopic but otherwise, and then trying to mobilize the patient, avoiding opioids to prevent constipation, things like that. So a couple of things, only you have to talk about it like 40 seconds.
I heard you, Anish, in one of the videos, you said that it is a group of multidisciplinary, multimodal group of programs that involving patient before admission, during admission, and after intraoperatively and post-operatively as well.
Yeah. There's a good paper on that one, but the problem with the challenge with FRCS is to say everything in 40 seconds. So each question you have to modify to answer within 40 seconds. So that's why we have to rely on the keywords.
Can I just confirm, Anish, that the boundaries for bladder cancer cystectomy lymph node dissection, it's up till level 2, isn't it?
Level 2, yeah.
So level 1 is below the common iliac, the division of the common iliac artery, and level 2 is above the common iliac but below the bisection of the aorta, and level 3 is which is going to be super extended, which is above the bisection of aorta up below the IMA.
So we can say that standard, extended, and super extended, because there was no lymph nodes in this one. Even if you go for a standard with the boundaries genitofemoral nerve and the inguinal ligament or the Clockett's canal in the lower part and the common iliac artery bifurcation, that should be acceptable.
And then the medial border is the ureter, lateral border of the ureters.
Lateral border of the ureter. Even if you say bladder, because in some places it's shown as bladder, that's also acceptable.
Okay.
And again, why we are doing the lymph node dissection? Because it can improve the overall survival, isn't it? Because if it is, it can predict the overall, not improve. It can predict the overall survival, because if it is N0, PN0, then survival is 80%, whereas it is half, 40% if it is lymph node is involved, N1. But to predict that, you have to remove at least more than 10 lymph nodes. And these are standard, because we have to when you